Welcome to this Target Oncology presentation in precision medicine called BCL2 inhibition in leukemia. I am Dr. Harry Erba, Professor of Medicine and Director of the Leukemia Program at Duke University, Durham, North Carolina. BCL2 has been a promising target, and the new clinical experiences with venetoclax bring great promise. Today we discuss the rationale for and historical experience with targeting BCL2, provide an overview of the venetoclax clinical data, and discuss future directions. Please join me in welcoming my colleague, Dr. Matthew Davids, Assistant Professor at Harvard Medical School and Medical Oncologist and Associate Director for the Center for Chronic Lymphocytic Leukemia, Dana-Farber Cancer Institute, Boston, Massachusetts. Welcome, Dr. Davids.
Thank you, Dr. Erba.
Let's begin. Why don't we start with a discussion of the goals of our therapeutic interventions for patients with CLL, and maybe even start with, do all patients need therapy?
So often CLL patients present with stage 0 disease, meaning they just have circulating lymphocytes but no other symptoms or signs of the disease. And actually we can safely observe these patients sometimes for many years. The indications for treatment have not changed. They remain advanced stage disease, which includes cytopenias, anemia, or thrombocytopenia, bulky organ-threatening lymphadenopathy or splenomegaly, or constitutional symptoms that are being driven by disease progression, so-called B symptoms. In the absence of those, we still observe, but patients often do require therapy, and we fortunately have a variety of different treatments that we can offer them now.
So when you start to evaluate a patient with CLL, is there anything besides stage of the disease, symptoms that you look at in determining treatment options and risk stratification?
So to risk stratify CLL patients, we have a number of different factors that we can send, and we find it useful to send these early in the course because it helps really predict how the patient will do over time. So really the key factors include FISH cytogenetic testing, which can identify a high-risk subgroup, for example, deletion 17p, which can have relatively rapid progression of the disease. Other abnormalities like deletion 11q are accompanied by certain specific clinical scenarios, like bulky lymph node disease that's sort of central and often not palpable, for example. And other factors like trisomy 12 and deletion 13q all kind of have a typical course that we know what to expect. The second factor that's very important is the IGHV mutation status. This can be either mutated, which is the more indolent or slow-moving CLL, or unmutated, which is a more steadily progressive disease that usually requires therapy within a few years of diagnosis. And at least historically with chemoimmunotherapy-based approaches had a much shorter duration of benefit from those treatments. So those are kind of the two key factors that we check, FISH and IGHV. But increasingly we like to send for TP53 mutation status as well. We noticed that these patients often do poorly, just like deletion 17p patients, and it's helpful to identify them up front, again, because it helps to predict the course of the disease, but also to select therapy.
I've heard some investigators and clinicians like to check karyotype as well. Is that something that you recommend?
Yeah, typically we do send karyotype. I think you have to be a little bit careful with that because you need a very experienced lab that's sending a stimulated karyotype. In CLL, we don't often see many abnormalities with a typical metaphase karyotype. And so if you have a lab that's experienced with doing karyotype and can do the stimulated karyotype, it can be useful. Mainly because we've noticed that patients, even on the novel agent-based therapies, do tend to have a shorter duration of benefit when they have complex karyotype, particularly if that includes deletion 17p as one of the abnormalities.
You know, I think a lot of times people wonder about what is this mutated form of the immunoglobulin heavy chain gene, and I find it fascinating. It really tells us something about the biologic subsets of lymphocytes that are becoming neoplastic, the pre-germinal center versus one that's already been exposed to antigen in the germinal center.
Right.
But it is you have to clone, you have to PCR amplify the variable region and then get it sequenced and look for a difference of, about 2% from the germline sequence.
That's right.
As I remember, there were some older assays that were felt to correlate with that, like ZAP70, CD38. Are these things that we should still be checking, or do you think we've moved on now to immunoglobulin heavy chain mutational status?
Yeah, it's a great question. So we often do still see CD38 and ZAP70 testing being done in various labs. And one of the challenges with these tests is that they are highly variable. And so even in a given lab on a given day, you may see variation in the level of expression of these. And so even though there's some value if you're not able to get an IGHV test, we do think the IGHV mutation status trumps those other factors. So if you have access to good testing for IGHV, it's no longer necessary to get CD38 or ZAP70 testing.